The broadcast is now starting. All attendees are in listen-only mode.
Good evening, everybody. It's 0 at night. It is Monday, the 9th of December. Tonight we have a guest speaker, Dr. Jay Gunkelman, and he is well known to the field and actually has recently decided to slow down a bit and do some retirement, but he's agreed to certainly do some webinars, and he's here with us tonight. Jay, you with us? Do I hear you?
Yeah, I'm here.
Perfect.
I am the undoctor Gunkelman, not Dr.
I
Gunkelman.
know. As soon as I said that, I thought, oh, but it happens to me all the time too. So we both have honorary degrees. Lovely. Any rate, I've sent out the announcement, and because we got started a little bit late, what we're going to do is just turn it over to you. Richard will shoot you a little, screen so we can see your screen.
Yep, we're on there, and
Yep, perfect. And so, without any further delay, I'm going to let you do a little introduction of yourself, Jay, and get started. Thank you so much for being with us.
Sure, I hear about myself more than I care to, so I'd rather just jump into the talk.
I figured as much.
Kind of like Sturman, show me the data. I just want to get started. I was around since a long time ago in this field. I started in 1972, and in the early meetings, there were really three groups of people. Academics, Sturman, Camilla, there was quite a few really good academics. There were military folks because DARPA was interested in the biofeedback world at that time. Richard Sherman, there was a number of military folks there as well. And then there were the consciousness hippies and that sort of thing. And I have to apologize for that. That was me. I ruined the entire reputation for the field for the last years. The field's been trying to shake off they're just a bunch of hippies, but we were a good-sized part of the beginning. But the academics really had two clusters. There were the academics that did state work, Camilla as a good example of that, the alpha state, meditative states associated with alpha, and the Menninger Foundation with the Greens. And they brought in Swami Rama. They were also into the alpha and alpha theta state work. And in addition to the state folks, there were clinical people. Sturman is the generator of the rest of the clinical world, and his work with SMR training, basically. So, I'm going to kind of take off where Sturman started and talk about the clinical applications in our field. And it originally started with epilepsy. One of the most crazy difficult things you can possibly imagine is somebody who's got epilepsy. This is not a minor dysfunction. This is a major disorder. And in epilepsy, people have convulsions. It can mimic psychiatric conditions. It can make people unconscious and in a dangerous way, falling down and hurting themselves. They can have absence spells. And a third of the epileptics that go to the physicians don't get any benefit whatsoever. Their lives are not benefited from any of the medications or approaches. And a third of people, they have their seizure events, they get diagnosed, and assume medication may end up taking care of them. About another third have some benefit, but they still have breakthrough seizures. And so there's this gigantic market up there that have intractable epilepsy. So neurofeedback really tapped into that as a condition. Here's an example of a paper. Hopefully you can see the whole thing without the screen overlay. And
looks fine. Looks good.
I can okay, good enough. This is Sturman's work from 2000. It reviews the background of his work. You've all probably seen the cat story a few times. sometimes all sorts of graphs like this, but ultimately he shows the mechanism of it at a network level, and he goes through the early work, including Lubar, who spun off of Sterman's lab, and others. He had a very active lab there at UCLA. So that as a paper basically would be highly recommended, Sterman 2000. And it summarizes his work. But more recently, there's a meta-analysis by Gabriel Tan and everybody here, Ute Strahl from Germany, Kaiser kind of representing Sterman's work, Corey Hammond. This group basically did a review, and they go and review lots and lots of papers. The bottom line, when it gets right down to it, is that they had an 82%, where's the quote here? Okay, summarizing all of that, they basically ended up with an 82% chance of improvement clinically. Now, what do you compare that to? You know, 82% of the people that were intractable epileptics, these were studies on intractable epileptics. 82% of them ended up with a benefit from the neurofeedback. And what do you compare that to? The intractable epilepsy treatment in neurology is surgery. And brain surgery for seizures is getting better than it was, but when you look at the literature about brain surgery for surgeries, at 3 up, they have a 50% chance of a 50% or greater reduction in seizure. And you know, that doesn't really sound all that impressive. And compared to an 82% chance, again, both with intractable patients, neurofeedback actually was a superior approach to brain surgery. Well, obviously, you know, epilepsy is a major area of application, and Sterman and people that spun off of Sterman's work, and Ute Strahl and people that spun off of their work, end up basically working on either SMR training, or alternatively, they'll end up with slow cortical potential training. And just to show you a little tiny bit of that, and this is kind of a classic 3 per second spike in wave seizure discharge. There's a little mark here where they found some evidence of it beginning. Now what they've done is they've compressed time. This is a second. Now this is a second. So this is the same discharge, the same little mark that started it, and they filtered out the low frequencies, and this is the high frequencies. What you basically end up seeing is the spiky activity and the EEG frequencies for slow and the low frequencies down below 3 hertz or so to end up getting seen in this. Now this is up here is the same thing with a little mark at the beginning and the brief little bit of the discharge, that all are here with the fast frequencies filtered out, just looking at the low frequency end of things. Now, the trick is that in Germany, they treat epilepsy with the infra-slow training, the slow cortical potential, different ways to talk about the same signal. What we're basically looking at here is that infra-slow content. And where we see the seizure discharge beginning, it's already underway. Here's the beginning. You can see it's already drifting up. Negative is up on some of these channels, and electronegative is turning areas on. And the areas that are turned on, the channels where it goes electronegative most, end up being the channels where we see the maximum amount of activity. Channels where there's not much to be seen don't really go electronegative. So the training by Burbaumer's lab and finally Uta Strel's lab, and now she's retired as well, was essentially they train you how to move electronegative, electropositive, up and down and up and down and up and down like calisthenics. Going up and down with it, they would tell you, oh, well, for epilepsy, you should be in the electropositive position. And you can see that the discharge finished over here somewhere, and it's heading electropositive. This is turning off. So the electropositive shift here off that seizure. So there's two approaches generally in neurofeedback. Number one, SMR training, which has been shown to be stabilizing, and infralow, slow cortical potential training. And those two approaches both tap into the control network. And the control network, by the way, if you hear up a storm, but what we've got is essentially evidence of the infraslow contents interaction with the oscillating faster EEG that most people in the United States have been more accustomed to. So they're both solid approaches. They both have shown to have good efficacy when we've looked at the research. Now, you know, I don't know if all of you have seen seizures really a lot, so let's actually take a look at somebody who's got some epilepsy. First of all, you know, when a major seizure disorder discharge happens, they're not that hard to see. You know, here we've got this about the size of the cursor, and it's about the size of that blue cell. That's 2,000 microvolts. 2,000 microvolts. So some of these are rather easy to spot. They jump up out of the background really quite dramatically. And what you see here are essentially a 3 per second spike in wave pattern, but some of this ends up with kind of a complex timing. If you look at some of these discharges happen a little bit earlier in some locations than others. And as such, as we're going through the EEG and scrolling through, this person has quite a few of these major discharges. You can see there's another one. And when you see these, most people see them as frontally prominent discharges. Once in a while, you'll see one that doesn't quite fully form. Notice in these two little kind of attempts at a discharge, there's actually spike and wave happening here when we turn it up. This is now 500 microvolts. It's the size of the cursor. So this spike here at T5 electrode basically is a major initiator here. And when we're training neurofeedback, normally SMR wouldn't, I mean, if you called it SMR training at T5, Barry Sturman would hunt you down and I'd probably help him. You know, SMR is only really coming from a very limited location in your thalamus. This aspect of the thalamus projects to the sensory motor strip, not to the motor strip, but to the sensory motor strip. And this ventroposterior lateral, VPL, the larger VPL, not the dot, but the larger VPL. Sometimes it's called the ventral basal nucleus of the thalamus as well. But it's this is the nuclear body that generates it. This generates vision. It goes to the back of your head in the visual area. This is the somatosensory integration area along with this in the parietal area. This is your somatosensory area, then motor, then you move a little further forward to premotor area. the anterior cingulate and the frontal lobe. So as you wrap around, you go from the back up to the front. And here's audition, the auditory cortex down here in medial geniculate. But this nuclear body right here is what generates the rhythmicity that we see as sensory motor rhythm. Well, where can you train SMR? Well, SMR is where sensory motor rhythm is. You can't train SMR where it isn't. The same frequency trained elsewhere would be a fast thalamocortical rhythm in the alpha band. Out of what most people would think of alpha, the neurology has a different concept of alpha. It's the rhythm of the back of the head that attenuates with eye opening. And it can range from 3 or 4 hertz at the low frequency end. Most people sit between 8 and 12, but fast alpha goes from 11 up to about 16. So the same fast thalamocortical rhythm of 12 to 15 can be seen in the somatosensory area, in the temporal area, in the frontal area, and so forth, but it doesn't mean it's SMR. SMR is restricted to the sensory motor strip. So where would you train it on the head? Obviously, you'd be somewhat restricted because it has to be from somewhere that actually generates it. So you'd have to train it somewhere centrally, C3, CZ, C4. Most people have been trained to do it at CZ or C4 symptomatically, but some of Sturman's early work was at C3 for specific epileptic discharges. So, it's a major approach. Now, most people know that I do a whole thing about phenotypes, and phenotypes are a genetically linked EEG pattern, and epileptiform discharges are one of those genetically linked patterns. So let's take a look at monozygotic twins. This twin has seizures, and again, I don't know that you need to be an electroencephalographer to see that we've got spikes here. These large discharges end up having spike and wave morphology. And as you go through her EEG, you can see they're not hard to find. They're popping up pretty much on every single page. Different locations. This is in the parietal area, PZ. That'd be a sensory integration cortex that took the hit there. This is a T4 temporal and phase reversals to the central area. So this is the motor strip and temporocentral along the motor strip. Back to the parietal, to the temporocentral. So they're bouncing around as to where the primary discharge is, but you can see they're really common. There's not really a page here that doesn't have epileptiform content on it. And you'd expect that. She's an epileptic, diagnosed that way. She's being treated with anticonvulsants. And as you can see, they're really not stopping this. So, yeah, she would benefit probably from some neurofeedback to augment her neurologist's treatment. The training that can accompany it would be highly beneficial. But you can see the PZ might be an area that you'd be interested in, and definitely you'd be training something in the central area because that's where SMR can be trained. Quite often, I end up putting, you have to have 2 electrodes on the head to have an EEG. And I quite often put one in the central motor strip to train SMR where SMR can be trained. And I'll put the other electrode perhaps where the discharge has spectral content. So you can actually operantly suppress the discharge with the same EEG one channel. So a montage, for instance, combining CZ and the C4 and PZ here could be used to train SMR centrally and to catch PZ for the discharges that happen there, to operantly suppress the discharge. That's the only thing I've done to change anything Sturman's done, is to try to pick your second electrode to somewhere other than the ear. And so it can go CZ to the temporal, C4 to PZ. Generally, SMR type training doesn't do so well going frontal, but temporal, central parietal, very commonly done. But you can see this one is just a real mess, and she's full of epileptiform content. Well, you know, poor young lady. Let's close her out, and we're going to pop up the twin without the seizure. Now, these are monozygotic twins, identical twins. And the phenotype model would say that unless you acquired something from a trauma or a surgery or something, they should basically have been dealt the same deck of cards. That they're going to be playing the same hand. Genetically, it's the same person. So we start scrolling through. She's got a little bit more muscle tension up front. She's diagnosed not with epilepsy at all. She has a learning disability, a sensory integration problem, which is generally something in the parietal area in the sensory integration cortex. Gee, I wonder why she has that problem. You can see that the two twins are essentially both gifted with the same, you know, outlier state of having epileptiform discharges, and they're frequent all the way through the EEG. So why would that be? Well, again, if you have the same genetics, you have the same EEG endophenotype, and the endophenotype determines your EEG pattern and also what kind of therapy you get, independent of your diagnosis. We're not trying to quibble with a diagnosis. This person probably has a learning disability, and the other person is having epilepsy seizures, so she's diagnosed as epileptic. But we look at this one and think, well, she'd probably benefit from an anticonvulsant to help stabilize, and both of them would probably benefit from neurofeedback, SMR type feedback, or potentially slow cortical potential feedback. And you know, there's good evidence that in the literature that this could be beneficial. So these are obvious monozygotic twins, and monozygotic twins are kind of difficult to come by always, but this pair ends up showing the genetics of epilepsy, basically having a commonality. So there's kind of an interesting circumstance that's come up. I had known of Sturman's work, and I'd helped a few people with epilepsy over time, but they were people that had real minor focal things and so forth. And I didn't really think much of it as a case series or anything, but more recently, I was approached by a counselor in Israel, and she said she had a young girl who's having uncontrolled seizures, and you know, she had recorded her baseline EEG back a few years ago, 2012, and you've seen this just a little bit ago, the same kind of a discharge. This little girl was had Dravet's, which is an intractable form of epilepsy, and you start having a neural development, and then you start having seizures. And this little girl had regressed. At 8 years old, she couldn't tie her shoes and she couldn't speak. And obviously, she's got discharges, but look where. This is C3. You know, all the people that have been taught, well, C4, CZ, that's where you train SMR. Well, what if this is a spike coming out of C3? Shouldn't you kind of hit the nail on the head and peck around it? You know, if you want to really drive something home, we've got to be on home base here. So I told the therapist that I thought SMR training would probably be beneficial. And she said, well, I'm a counselor. I can't treat epilepsy. And I said, well, you're not going to treat epilepsy. You're going to train her how to operate her brain. The neurologist is treating her epilepsy with the medications and everything that she's on. All you're going to be doing is helping her to operate her brain a little more efficiently. You're not actually the treating physician. You're the counselor trying to get her to optimize her brain function in it with operant conditioning or instrumental learning. And so you're just teaching her how to operate her brain a bit better. You're not treating her. You're not the physician monitoring her meds, doing EEGs every 6 months or so to check to see how things are going. They're going to be doing that. Just do C3 SMR. So she agreed to it, and over a little bit of time, 20 sessions later, she had been doing neurofeedback as a counselor for some of her ADD people, and they're used to doing a repeat evaluation at 20 sessions. And so she sends me the repeat, and I told her at first that neurofeedback for epilepsy is known to go 100 sessions or more quite often. So repeat at 20, sure, we'll look at it, but don't expect miracles. Well, the first report had an automated spike detector which can be passed over the EEG. And the automatic spike detector detects spikes, uses this algorithm, how spiky the spike is, if there's an associated slow wave, all these fancy settings between 20 and 70 milliseconds, 150 milliseconds, but not less than 50 to get to the slow wave from the start of the spike. All this stuff has to be true for it to identify it. So the spike detector detected spikes. Well, gee, C3, there's a little bit of T5, here's a C3, a C3, a C3. But the first one spotted over 200 spikes. This follow-up was only 100 and something. And the therapist was all excited because she had the software, she played with this, and she saw the spikes, as awful as they are, had dropped way down. The spike averaging, now we can run a whole bunch of these spikes together, and you can see the C3 will be the one that we end up with here. But you've got map that, the spike and the slow wave. Yeah, jump to the other side. So, and jump it back. So the spike is essentially a combination of the source over here and the sink. The polar opposites are in opposite color. And so here's the spike field, and here's the wave. And they both basically involve C3 really strongly, but also some left temporal and obviously frontal skewed to the left. All that area is being involved in it. So, she asked me, geez, is this progress? I mean, we still have a spike. We can see all the technical detail of the spike, but is this progress? It went from 200 and something to 100 and something, and is that progress? I said, well, it's moving in the right direction, but quite honestly, it's gone from god awful to terrible. What's the difference? I mean, but keep training. I mean, it looks like the same brain. We're still getting spiky activity at C3, and it's cut the spikes in half, although it hasn't changed the little girl, is it? And she said, not really. I said, well, what do you mean by not really? She said, well, she's making noises now, but she's not talking. And, I said, well, run another 20, 30 of them by, and we'll take another look. So then comes her next recording. And this is 42 training sessions. This is May. So October 2012 to May 2013. And the therapist starts the recording, and as they're rolling on the recording, they're not seeing spikes. So, and this is lambda, it's eyes open, this is lambda at the back of the head. So that's Sharpie stuff, but it's not spikes. And the therapist took a big breath and didn't want to even take another breath. She'd break the spell. this EEG was clear. There's no C3 spike. And it went to 0 spikes detected with the automatic spike detector. Well, this is suddenly looking like progress. And we asked what the little girl was doing. And she's speaking fluently and she's riding a bicycle. So what we've basically seen is the turnaround in a life that's expected to have no real expectancy. I mean, the Drebitz is a terrible waste of a human life, that you don't really have quality of life, you've got life. And it's an awful circumstance for a parent. Suddenly, they've got this little 8-year-old, and she's basically able to speak, and they're happy with the outcome. So I'm thinking, geez, an intractable epileptic's just been turned around. Ignore that. So this has essentially just been turned around. We've had a little girl who had no expectancy of a life of any sort other than being mute and incapable, to a little girl that's a happy bicycle riding little girl. Now they tested her and said she's not as sharp as some little 8-year-olds. I said, well, you just woke her up, and you literally just woke up this. It's now able to interact with the outside world. Give her a year or so before you start to categorize her as somebody who isn't all there. And they agreed to try to not create a category for her until she had another year of experience. And she did sharpen up pretty well. So I started to think, well, intractable epilepsy is a pretty rewarding circumstance when you observations on an EEG and pick up the spot of a discharge and prescribe a neurofeedback protocol and turn a life around. That's pretty amazing. I can see the power in Sturman's work, and it's really quite rewarding. And I'm thinking, well, geez, this intractable epilepsy stuff is really quite something. And I get more contacts of people that have intractable epilepsy. And one of those is a little girl, Isabella. And Isabella is a happy little girl. She had strabismus, a little eye movement difficulty with quote lazy eye, and the therapist suggested that they do some tennis, and she started to play tennis as a little girl, and she really enjoyed it. She got really quite good at it, but she wasn't doing all that well. They thought she wasn't really keeping up in school, and the neurofeedback person that they approached at the time concluded that there was ADD and anxiety, and they trained for 55 sessions, and it was going along pretty well. Tennis excelling, very excited about her work because she was now working with Sue Wilson, an old friend of mine, Vieta, Sue Wilson, a sports performance psychologist out of Canada. And they basically moved. So they moved over to Spain, and Barcelona is a great spot, but when she got over there, things started to fall apart, and they couldn't quite figure anything out. She was getting slower, unable to really see things, dizzy spells, couldn't even score a tennis match. Finally, her mother noted that her eyes were flickering, and she was not really conscious during it. And they ended up with a formal diagnosis of temporal lobe epilepsy. Here she is in the ICU. They're having 250 seizures in a day. generalized tonic-clonic, some absence-like, and there were lots of triggers for seizures, but they finally had a scheduled appointment, but just before the appointment, she went into status, and a seizure that won't quit is status epilepticus. And you have to stop those, or the brain will quit working entirely, and you'll be brain dead. You can have SUDEP, S-U-D-E-P, sudden death of epilepsy. So they got her in. They injected her with the diazepam-related medication, stopped the seizure. But they basically told her at the time, she's got epilepsy, there's no cure. Medications were not really likely to help, but this is a tough circumstance, but essentially kind of good luck. So she really was non-functional. She couldn't go to school. She couldn't do basic self-help, dressing herself and so forth. She was having, this is the trigger. She would have epigastric pain, and a severe epigastric pain, and then an aura of some sort other than that before every seizure. The fact that she had epigastric pain told me that the source started deep in the sylvian fissure. There used to be a term, I mean, there's an international classification system now for epilepsy, but before that, there was all sorts of, petit mal and grand mal are not formal names even. But there was one basically that was called abdominal epilepsy, where the seizure was a smooth muscle contraction and the source was deep in the sylvian fissure, and they had severe stabbing pain abdominally. Well, I'm thinking to myself when I caught her story that she's got a discharge in the temporal lobe that's triggering all of this. And sure enough, we ended up, go back to this, generalized seizures. Best results they got with 3 medications was down to 80 seizures a day with 3 anti-epileptic compounds. And they were telling her that they would suggest they were going to try surgery on her right temporal lobe. So I'm looking at her EEG, and first of all, you can see the beta. This is 1/5 of a second between the powder blue lines, and you can count them 1, 2, 3.5 is 18. This is a beta spindle, and that builds into a polyspike burst. Beta spindles like this were originally described in the 1930s by Gibbs and Gibbs as a form of epilepsy. Beta spindles can be seen in easily kindled cortex, not always epilepsy. But this is her discharge happening. And I always go, well, that's the discharge. What happened just before it? Where did it come from? And as I'm looking around at her discharge, and let me go back. These things are sensitive. One more. Okay. If you look carefully, the left temporal lobe, T5, has a sharp and slow transient just before this kicks in. The right temporal lobe afterwards has this. And the right temporal lobe is kind of dull by comparison to the fast activity on the left side. And I'm thinking, I think this is being triggered off this left temporal area. And I suggested to them that they try a CZ to T5 SMR training, which is eventually what they ended up with. But this was her seizure discharge, over 1,000 microvolts, major tonic-clonic seizures when they happen. We basically got her back because she was motivated to play tennis. That's her core thing that motivated her to get up add it and do something with her tennis. So they built everything around her tennis. And she was really weak, and she could only do very brief training sessions. And they had a multifaceted approach, a little bit of everything, but neurofeedback was at the core. And other things had been applied prior to the neurofeedback, and they hadn't really gotten anything under control. So the neurofeedback was the key addition here. So Sue got the data up to me. I recommended the protocol, but you know, they're in Spain. That's a long way for me to go, and I don't travel well anyway. So I got them to chat with Linda Walker, who hooked them up with the hardware and trained the mother face-to-face on the equipment, got her up and running. We also got Antonio Martins Murrow in England to hook them up with a local tech so they could get EEGs done. The tennis coach stuck with them, and there are a lot of people that are part of the team here. But Linda Walker did remote training sessions with them, supervising the training online of the mother, who's a clinical psychologist, but not practicing that. She's in business. Was there any progress? Well, September to June, you can see, you know, there's changes. The Z-scores in the beta really quite striking here. It's the frontal prominence to the beta was really striking, and it's gone. Here's the spectral delta, theta, alpha, beta, high beta, and the beta here is not muscle. This is all beta spindles, and the slow content actually has some skew off to the left side. This is the EEG after the training. There's still some slower stuff on this left side outside the normal range, but it's not so far out that the Z-score person would end up having it as a flag. This is essentially the result of a brief stretch of training. Let's see what happened. They started out 2015, status epilepticus, large number of seizures. By June, they just started the neurofeedback. They were at about 90 a day. They'd gotten to about 80 at their best, but they were at about 90 a day. By August, she had discontinued all of her medications because they made her so groggy she couldn't play tennis, and they were still having 60 seizures a day. Now, she was playing tennis, and she actually won a nice little tournament, but the problem was that she would have seizures in the middle of a match, and unless you can recover yourself, there's a personal adjustment period of 20 minutes to let you go use the John or something, and if you can get your stuff together by then, you can continue. But there were games she had to forfeit. She was ranked at 1,138th at the time. That doesn't sound so good to me, probably isn't, but then I don't know tennis, so I don't really know. But she ended up ranked at 78 as we went through this. But her seizures basically started to change. She didn't have any more seizures in her sleep as of 2016, February, down to about 15 a day. She didn't have cessation of breathing, down to about 8 a day by March. September is the last time she actually fell with a seizure. They're down to about 5 a day. And that tells me at the frontal, this tells me the brainstem's not getting hit so much. This suggests the brainstem as well, in sleep regulation. Last drop seizure, frontal lobe is now, and imagine a network of Tinker Toys, and the network is shedding spokes and hubs, and this just dropped off the frontal lobe hub. The last physical shaking convulsion, down to about 3 a day, but not really that intense. So they're starting to shed off the motor strip, stiffening, but not really complete. Loss of consciousness less than 2% of the time now. No more epigastric pain, down to 3 a day. Still can stiffen, but not really seizures. And the fact that she was down to the no more epigastric pain, basically, that's a long stretch of time. Hundreds, plural, of sessions. I think they were somewhere in the 500 session range when last I knew. She, by the way, didn't just win this tennis game in Madrid. She's got a Division I tennis scholarship, full ride scholarship at a university here in the United States, where she's currently just finishing her first year. So she started out doing neurofeedback, increasing SMR for seizure reduction. But now that her seizures don't happen, she does it for relaxed focus. And she used to lower the theta to reduce the recruitment of seizures. Now it gives her a better, better attentional skills. Reduced high frequency beta, less impulsivity, better shot selection. Alpha regulation, quieter, to quiet down the seizure focus, some alpha training, and she uses that for visualization. So the purpose of her training has shifted from stopping her uncontrollable seizures to optimizing her function, which really isn't a change in protocol, it's a change in intent. We don't come up with a different protocol for somebody because they want to play tennis than we do if they're having seizures and they want to do something else. I mean, I'm not a tennis coach, but I'm happy to have somebody optimize their brain function. And if they're playing tennis, it'll probably help their tennis. So what we basically have now is Isabella as a tennis player who's really got an explosive game. Remember all those beta spindles? Beta spindles are also explosive energy, and she's got great reaction time and plays a hell of a game of tennis. Deserved her Division I full scholarship. Anyway, that's the story of Isabella, and she's one of 6 in the Intractable Epilepsy series that I've got going at this point. A rather impressive young woman. Always happy to see her succeed. And again, her big success now is that she's a Division I tennis star. Her assistant coach had a sister who had epilepsy, and after this first year that she's actually succeeded in, they're going to start to feature her recovery, not just that they've got somebody who can play tennis, but her whole story with her recovery and everything will start to be featured. Anyway, that, you might think to yourself, well, hooray, good story, hurrah, epilepsy, but geez, I don't treat epilepsy. I work with ADD. Well, let's actually take a look at treatment failures in psychiatry for a second. This is a nice little publication. They had just under 400 people in the study, and these were people that had been referred to a psychiatrist, Dr. Tarnow, Ron Swatsina. Dr. Swatsina does the recordings of the EEG. We do the analysis on it. And what these patients represent are people that were referred because the psychiatrist that had them before couldn't figure out what medication to work with them on. That they were not treatable with medications in psychiatry. What they found is basically that if you are not responding in a normal way to your meds, there's a few things that it might be, including epileptiform discharges as one of them, beta spindles is another, focal slowing is another, and low voltage slower and encephalopathy being the last of them. Difficult to treat cases, the most common thing to predict that medication was going to be a failure is unexpected epileptiform discharges. So, what's that got to do with you? Well, unexpected epileptiform discharges is what you run into all the time. 20% plus of the ADD population have unexpected epileptiform discharges. 40 to 60% of the autism population. So my bet is that you got people walking through your door that have unexpected epileptiform discharges that aren't necessarily as gross as the 3/second spike in wave, but they're still significant. What happens when you actually treat them? Well, here's a paper. This is a retrospective analysis, so it's looking back in history at the treatment outcomes of non-epileptic patients when we found epileptiform discharges, and we recommended that they treat them with an anticonvulsant medication. And we quite often recommend the anticonvulsant and the neurofeedback together. Once you get the seizure discharge under control, you can peel back the anticonvulsants. Well, what did they find? 85% success. Now, it's not easy to find an 85% success figure in therapy, but out of 76 treatment refractory cases, 65 improved. Of the ones who got worse, there weren't many, but 3 out of the group had a seizure medication-related concern of subtle rash, which wasn't necessarily diagnosed as Stevens-Johnson, but there was a rash and they discontinued, or alternatively a fever. And just to be sure, they discontinued the anticonvulsant. So that was the more severe ones. But that's 85.53% success when treating the discharge. Now, you basically end up with a lot of your patients, unbeknownst to you, walking through the door with epileptiform discharges. And if you knew that the discharges were there, psychiatrist, it might change what you actually prescribe. Because if the kid is acting out, you might give him an antipsychotic, and the antipsychotic drugs make the epileptiform discharges worse. We've actually got a paper published in a European Journal of Psychiatry, and it was an invited paper, and it challenges the field of psychiatry to change the standard of practice in autism specifically, because there's such a high percentage of epileptiform discharges in autism that if you don't do an EEG when you see an autistic kid for the first time, you don't know if they've got epileptiform discharges or not by the behavior, because they're not having convulsions, they're autistic. And if you actually treat them with an anticonvulsant, they improve substantially. But if you give them antipsychotics, they get worse. And it's not unusual to get Remeron, or there's a bunch of antipsychotics that can be given inappropriately to autistic kids for behavioral control. There's a stimulant for the attentional problem, which if you're not controlling the seizure discharge, can also drop the seizure threshold. If you're treating the discharge, you may treat the person's attentional issue, but it might go away entirely with the administration of an anticonvulsant and appropriate neurofeedback. So, 40% of your clients with another 20% on top of that have non-specific paroxysms that we find benefit from the same approach. In the phenotype model, I don't differentiate specifically diagnostic epileptiform discharges from paroxysms. Just because a burst doesn't have a spike embedded in the middle of it doesn't mean it doesn't need to be stabilized. And the same kind of therapy stabilizes. So I'm not really oriented towards the DSM categorization. I'm interested in what makes things work. And if you see a paroxysm, an anticonvulsant approach is what basically works best. So, you know, you're going along and you run into a person who's got seizures. Quite often beta spindles are associated with this disorder, but beta spindles are also associated with insomnia. When we looked at beta spindles, the sleep onset and wakefulness, sleep maintenance, and spindling excess beta, what this was is a research domain criteria paper where we basically queried the database of about 1,000 something patients that Ron Swatzina had set up, IRB approved for access, and Martijn and Sebastian Olbrich and myself had done some stuff on vigilance modeling, and I had talked about beta spindles and that. Anyway, one thing leads to another, and Martijn finds out that we've got this data set to query. And he said, well, it's research domain criteria time. Don't look at the DSM, just find an EEG feature like spindling excess beta, and we'll correlate it with the other testing independent of the diagnosis and see what it corresponds best with. Some impulse control, but primarily insomnia, beta spindles. So what we basically found is that we're not talking about beta that's in epileptiform discharge cases. We're talking about spindling beta excess, not the beta associated with the paroxysms. And what we're basically ending up seeing is this frontocentral, a little across the front, but it's basically off of these electrodes. And because that's basically where we see them, it's a spindling excess beta. This subgroup at the bottom are out of the group of beta spindle patients. We pulled some that were beta spindles in ADD, ADHD, because there's a subset, about 10% is a pure type and another 10% is a mixed type. So as high as 20% of the ADD population will have beta spindles, and they're basically in the same basic feature here. So the beta spindle that we see ends up being an easily kindled cortex. Now, let's assume that you're falling asleep. You start out in stage awake, and you slip down to stage 1, which is drowsiness, and then you slip into stage 2, which is full of vertex sharp waves and spindles. The spindle in a vertex sharp wave and spindle complex is SMR. It's a sleep spindle, which is the same damn thing as SMR. Same nuclear body, same morphology, same basic generators, and it's SMR. Now, these are beta spindles, not SMR. These are faster than SMR. These are easily kindled cortex. Now, a vertex sharp wave in sleep is the response of your brain to a stimulus. And you respond to the stimulus by waking up. Or if there's a sleep spindle afterwards to stabilize you, you can continue to drift off in stage 2 sleep. Drink water. So, stage 2 sleep vertex waves, if they're followed by a SMR sleep spindle, you fall asleep better. And during sleep, you wake up out of slow wave sleep and up into REM sleep for a REM period, and you pass through stage 2. If you pop a vertex sharp wave in stage 2, you will wake up if you don't have a good sleep spindle or SMR. So sleep onset and wakefulness forms of insomnia are because you have too much excitability and not enough SMR. And we basically train SMR in people that have beta spindles and suppress the beta and help stabilize them. Now, sleep onset has been shown to be treatable with SMR. There's a very nice study that came out of Salzburg, Austria, the Consciousness and Sleep Lab of Wolfgang Klemisch. In 2001, we invited him. He couldn't come. He sent his senior researcher over, and his senior researcher attended the ISNR meeting and went back over to Germany, having learned that the brain can self-regulate with some feedback. And on the way back from the train station to the university, Michael Doppelmayr was the researcher who came over. He and Wolfgang Klemisch chatted on the way back from the train station, and they came up with 3 years of research to do using neurofeedback. And it didn't have the pejorative of the hippiedom here, and that's their major research lab, one of the top 60 research labs in the world, not EEG labs, research labs in general on anything. And their lab had already identified that slow alpha people have poor semantic and declarative memory, fast alpha has superior semantic and declarative memory. Well, they found that if you train SMR, you end up with the faster alpha fostered, and you end up with an increase in semantic and declarative memory. You can train the person to speed up their alpha 1 cycle a second, and you improve their neurocognitive function. So, you know, academia over there took off with feedback. That it was a great thing. They also found anecdotally that the people said that they could fall asleep much easier. So they set up a study, a really well-controlled study on sleep. And their well-controlled study on sleep basically ended up with people getting 10 sessions of SMR training, and they measured with actigraph technology and in a fMRI chamber. They found that the SMR was the same thing as a sleep spindle, and that the actigraph technology showed that they were falling asleep better and staying asleep better. So, you know, really positive outcome. That was replicated independently with the same basic methodology in Graz, Austria, at Kurt Furcheller's lab. So then they tried to work the same thing with severe insomnia, and they found a trend in the right direction, but wasn't significant with severe insomniacs with 10 sessions. I hypothesized that that was an insufficient dose, that they simply needed more training. That was actually tried. The 24 training sessions was done by Diego Rodriguez. Just got his PhD out of Alliant University, and his dissertation was basically SMR training for insomnia. And he got severe insomniacs, just like the failure study in Germany, did 24 sessions and had good outcome. The Australians worked with elite athletes that have excess beta spindling as a common finding and insomnia as a common finding. And we did SMR training with the elite athletes, 24 training sessions, and self-report logs and actigraph technology showed them falling asleep and staying asleep better. So, for an elite athlete, sleep is critical. If you don't get slow wave sleep, you don't get the growth hormone, which doesn't allow you to recover from the wear and tear of the workouts you're doing. So sleep is critical. And, you know, at elite level, if you're not sleeping well, you're probably not going to stay at the elite level, because its competition is pretty stiff at the top. So what we basically have is beta spindles can be dealt with SMR. Insomnia can be worked with SMR, and sleep can be facilitated with SMR. Want to make somebody who has epilepsy have a convulsion, deprive them for a few nights and they will end up having one. It increases the likelihood of just disturbing sleep for one night, increases the likelihood of seeing a discharge in a known epileptic by 50 to 70%. And that's, you know, pretty good odds. You think, well, activation of epilepsy, well, don't you do that with photic stimulation? Photic stimulation only has a 4% additional yield above base EEG, resting state EEG recording. And sleep deprivation is 50 to 70%. You know, sleep deprivation is the acute activator. And now most of the epilepsy labs don't just do a routine EEG, they do multiple recording days, a 1 day or 2 day recording where you walk around with a recorder and a little button you can push if you have an event. And if you're in the lab, it's on video. You're in a room for a few days and being videoed as well as having the EEG recorded. So long-term recording ends up being a better way to spot the discharges that are subtle or rare. Anyway, my guess is that unbeknownst to you, you've had people walk through your door and be trained in your lab that had epileptiform discharges and you just didn't know it. And if you knew it, you might have actually been a little bit more focused on stabilizing their brain in a different way. I've seen too many times when the EEG has had the epileptiform discharge thrown away as though it's an artifact. If you're looking at an EEG throwing out a piece, you should know what you're looking at. The piece that you threw out shouldn't be an epileptiform discharge. When in doubt, you can always share the EEG image and chat with your friends, network with folks that know EEG. That's an absolutely impossible learning curve. Nobody's at the top. If somebody says they've mastered the EEG, run. They're dangerous. We're all students of the EEG. We're all trying to increase our knowledge. And you need to network with people that are on the same learning curve. Some will be a little above you, some a little below you. Don't ignore the people below you. They need every bit of help just like you do and just like I do. So let's all struggle up to the next level on the learning curve, and sharing your data so that people can learn from your case examples is a good way to do that. And a learning network with people is also an excellent way to do that. One of the reasons I don't mind in my retirement continuing to do some talks. I'm happy if there's questions or a period of comments or anything. I didn't know how long you were wanting me to go.
Well, we've taken you all over the hour, which we certainly appreciate. Richard would have to unmute people if you want to stay on for a couple of more minutes to see if there's any really quick questions.
Absolutely fine with me.
Richard?
I'm unmuting people now. Let the unmuting begin.
It does take a minute or two, Jay. He has to do it one by one. Great talk. Now, one of my questions while he's unmuting folks very quickly was that when we looked at that diagram, there was somebody who had a lot of beta spindles at FZ. Would you train SMR at FZ for that?
No, but you can do SMR is like standing on the brakes, tapping on the brakes, and you're trying to stabilize. Now, you can't drive a car by standing on the brakes. You've got to actually excite the accelerator once in a while to keep things rolling. So it's not unusual to use a suppressed training as a counterbalance. And the C4PZ SMR as an example, or CZ to the temporal lobe, or CZ to the ears. For the SMR, which is at the vertex, which is going to pick up some of that. But the FC as a suppressed to counterbalance. Now, suppressed training at one point had been patented as a protocol. You can feel safe to do suppressed training at the midline without violating anybody's patent. The Norica protocol had patented the suppressed training at the frontal midline at one point, but I successfully told him, and I had been doing it for a long time before his patent, and that I was going to continue to violate it. And he had 1 year to sue me to exercise his patent rights, or he used his patent But if he sued me, he was going to definitely lose his patent anyway. So he just grumbled and it all went away. So you can do suppressed training at FZ and not worry about paying somebody a patent right.
Perfect. All right. Other questions?
Hi, Jay. I have a quick question.
Okay.
So have you ever had anyone that has increased incidence of seizures with uptraining SMR?
In fact, during training, it's not unusual to end up having seizures come and go. Little Maggie's case I didn't mention in the case series, she's pretty well known. She had a nice little video shot about her. I just didn't think I was going to have time to show that one as well. But Maggie's case, as an example, she's I think maybe 17 training sessions in, and she had a really major seizure at that point. All the families were telling her family, "Oh, you got to quit that neurofeedback stuff. That's what did it. The doctor told you to do it at your own risk, and you better quit it." And they stuck with it. It's not unusual when you're doing training in a system for that system to activate a bit, but I don't suggest that it's have the seizure usually for a reason. If you're doing SMR training and you're not doing a counterbalance, it may be making the patient more sleepy. It's a stabilizing protocol, and if somebody gets not wide awake, not all the way asleep, but in between is a transitional state. And in the transitional state, discharges are potentiated. So if you get hyperstable, groggy, sluggish, sort of an outcome from the SMR training, you haven't counterbalanced it. And it's not unusual for that to end up being the problem. SMR is not ubiquitously positive outcomes. The SMR training blindly can run into problems. If you've got mu that stick into the SMR frequencies in the C4 area or the C3 area, and you train SMR, you potentiate mu, which is there because of a disconnection from the frontal lobe, and you can have a worsening of the frontal lobe disconnection problem in ADD or autism, and that's a potential. The other possible thing is people that do SMR training that run into very fast alpha, that's got alpha bumping into the 12, 13, 14 hertz range. Again, it's faster than most people think of as background alpha, but it's not at all unheard of. My background alpha sat at about 13 hertz most of my life. So yeah, I've slowed down. I'm at about 12 now. So part of the documentary they shot on me, they brought in recording equipment and told me I had to tell them what my EEG would look like. And then they recorded me. They had to analyze it live on camera to show what, whether I was right or not. And I predicted all the pathology I'd see and everything. So anyway, it's not ubiquitously linear progress in a seizure case. And when you actually focus on the motor control network, you activate that network. Sometimes you actually end up with a temporary resurgence of seizure issues. It's not unheard of. And again, there's usually a reason. If you're doing training with an epileptic and you're getting a worsening of the seizure activity, stop the protocol, figure out what's going on that's not right, and then resume. But hit the pause. It's not the no pain, no gain, plow through it, because if you're doing something that's not quite right, it's time to fix that, not just proceed.
Thank you very much.
Jay, I'm curious about the ketogenic diet. I trained a young man who had spina bifida, and he went on ketogenic diet because his mother was a dietitian, and we did 40 sessions, including some SMR. He had marvelous results, but I'm wondering, is there good research that shows ketogenic diet is also complementary to
Yes.
decreasing seizures?
Absolutely. The ketogenic diet's an extremely major aspect of intractable epileptics. If if you're going to respond to Tegretol for the first medication, you respond positively, they're not going to talk to you about ketogenic diet. But if you try one or two and you're not responding, they start to add on the things that can end up helping. And ketogenic diet, CBD, those kind of things end up being added on at that point. The ketogenic diet by itself for some people is sufficient, but it's generally not. It's a rare person that can get control with that and that alone. You have to understand that the ketogenic diet increases brain metabolism, and that's probably its primary impact. It also has a stabilizing effect on the brain, and that's where the decrease in discharges is concerned. But the increase in voltage is also fairly substantial. A brain that doesn't have ketones metabolically is dependent on blood sugar only and doesn't burn ketones. If you add ketones to the metabolic cycle, you have about a 40% increase in the metabolic support for brain function. And especially in seniors who have a very low voltage EEG, adding the ketogenic diet ends up being a very major piece of recovering their brain function.
Thank you.
I have a question. When you train SMR, what's the range in terms of the bandwidth? Do you pick and choose, or you always do 13 to 15, 12 to 15, 13 to 14? How do you make that selection?
When in doubt, and people can have SMR actually at quite a range. Gary Sturman and David Kaiser found an autistic kid that had SMR at 10 hertz. And how do you find it? Well, you let them go to sleep, and you look for a sleep spindle with after a vertex sharp-wave. Stage 2 sleep will tell you what the SMR frequency is. And if you see it at 10 hertz for a sleep spindle, you've got a 10 hertz SMR. Most people have a sleep spindle in the normal sleep spindle range, about 13 hertz. Classical EEG literature will say sleep spindle 12 to 14. Barry Sturman found 11 to 19 in the range. Now, he wasn't studying autistic kids, and that one autistic kid had a 10. And you think, well, at what age? Well, your sleep spindles develop pretty well at 1 year of age. You can sleep pretty well at that age, you know. The sleep spindle adult tuning. So it's not like your background alpha where it's going to mature up and you got to wait for it to get into the right band range or something. You've got it at age 1. It's your SMR tuning. Now, most people sit between 12 and 14. Sturman had 11 to 19, group average at 13. So it's rare that they're faster, but there are some that are. Most everybody's in the normal tuning range. I look at the EEG, and if there's a piece of it that's got sleep in it, we'll confirm it. We'll assume the 12 to 15 unless otherwise indicated. And it's not that hard to run into somebody that we run into only the autism spectrum where we found people down below the 12 to 15. Most people sit at about 13. I've seen some that trigger the 12 to 15 because they're sitting at about 15. But it's more common to have them sitting at about 13.
Well, I guess it's a little bit of a challenge because I don't have a way to measure people when they're sleeping.
You'd be surprised at how many people actually are sleeping. Let me diverge for just a second here. And here's a paper that you should familiarize yourself with, actually. Sleep phenotypes of ADD, ADHD. What they find is between 25 and 50% of the kids that are diagnosed with ADD, ADHD have either a primary disorder of vigilance, and they mimic narcolepsy. They basically can't stay alert and awake. If you let them sit, they'll fall asleep. And if you have kids falling asleep in your chair, they may have this primary disorder of vigilance. Some of them had delayed sleep onset latency, which is essentially a risk factor for later life bipolar. But these are people that go to sleep late. They don't want to go to bed, and then once they're asleep, they tend to sleep way late. That delayed circadian rhythm is treatable. It's a treatable sleep disorder. Bright light in the morning, melatonin at night. You can reset your circadian delay. Another group that actually have a phenotype here with a delayed sleep onset. The next group is sleep disorder breathing, apneas, hypopneas, restless leg syndromes, or periodic leg movements, another group. And they're treated typically with dopamine compounds. And then finally, there's a group of people that actually have seizures in their sleep. Little Maggie had electrographic status epilepticus of sleep, ESES, specific kind of epilepsy. It happens in sleep. Anyway, you know, a whole bunch of your ADD kids actually have a sleep disorder. We run our EEGs 10 minutes eyes open, 10 minutes eyes closed. And the 10 minutes eyes closed, we follow the vigilance model. And if they fall asleep, stage 2 sleep, before the 300-second mark, 5 minutes, that's a failure of a multiple sleep latency test segment if you're in a sleep lab. You just fell asleep precipitously. And if you did that on the average 5 times during an afternoon trial, they'd end up having to do an all-night sleep study on you. So we see a large percentage, actually a surprising percentage of the kids that have been diagnosed with ADD that basically have a sleep issue. And we send them to sleep labs. If you can't stay awake for 5 minutes, we send you to a sleep lab. And Ron Swatsina walked his little 12-year-old skinny kid into a sleep lab, and they just about laughed him back out the door. Now, you know, most of the people that they test are like me, overweight, older guys, snoring a little more than they should, and, you know, having apnea thing, and, you know, they get in there and they do CPAP on them and they're okay. Well, this little kid was hooked up. They had a doctor's order, so they did the test. A little kid was hooked up. It was the worst central apnea they'd ever seen. When he went to sleep, he quit breathing. He had to wake up to breathe. Now, not wake up, but wake up enough to breathe. And as such, he never got deep sleep. And he was a mess because his sleep was messed up. And once he got on CPAP and was actually restfully sleeping for a few weeks, all of his behavioral problems kind of faded away. It's important to realize that sleep is a critical piece of your attentional problem, and kids that have ADD that are staring you in the eye, you know, looking like they're awake, may be in a drowsy state, and the EEG can kind of tell that. Anteriorized alpha and anteriorized theta are both decreased vigilance states in the vigilance model. Now, they're not sleep, but they're decreased vigilance already. Anyway, I don't want to end up taking up your entire evening, but it was fun for me. I hope you enjoyed your time too.
Jay, it was excellent. Thank you so much.
Really, really, really amazing information. Most appreciated.
Thank you so much.
Thank you.
My pleasure. I only do it for the fun. So.
Well, we need to learn.
All right, Jay. Well, we're going to let you go because it's dinner time. We're close to it for you out there on the West Coast. And most of us, if we haven't had dinner, are probably ready for it. So,
no doubt.
Thank you so much again. Best wishes to you and yours for the holiday.
I'd say good night, but I think it's bon appetit.
Yeah, for you, bon appetit. For us, good night. And best wishes to you for the holidays, Jay. Thank you so much.
To everyone, too. Bye-bye.
Bye-bye.
Bye.